Hello and welcome back. Today we will be talking about the best and latest group of drugs currently licensed for weight loss, Glucagon-like Peptide-1 or GLP-1 agonists. These drugs were first discovered as a treatment option for patients with type 2 diabetes. It was noted that patients on these drugs lose weight and therefore they were investigated for their weight loss potential. There are currently 3 drugs licensed for weight loss in this group. Liraglutide, which is also known as Saxenda, being the trade name. And Saxenda was first licensed for weight loss in December 2014 by the FDA in the USA, followed by approval in Europe and the UK. Then came Semaglutide with a trade name of Wegovy. And finally, Tirzepatide with a trade name of Zepbound in the US and Mounjaro in Europe and the UK. Tirzepatide was only licensed for weight loss in November of 2023. Interestingly, Tirzepatide is a dual GIP-GLP-1 agonist. GIP stands for Gastric Inhibitory Peptide or Polypeptide, but it also stands for Glucose-Dependent Insulinotropic Polypeptide. We will explain what GIP is later on. Both GLP and GIP are the main incretin hormones that are produced endogenously by the body. GLP-1 is produced by the intestinal L cells. This diagram shows the mechanism of action of GLP-1, which is highlighted in green in the top half of the diagram, and GIP, which is highlighted in blue on the bottom half of the diagram. We'll start with GLP-1 on the right of your screen with the pancreas and move counterclockwise. So on the pancreas, GLP-1 stimulates beta cell proliferation, insulin synthesis, and insulin secretion, and at the same time it decreases glucagon secretion. On the liver, it decreases insulin resistance, decreases liver glucose production, and decreases hepatic steatosis. On the adipose tissue, GLP-1 increases insulin sensitivity and therefore it increases the uptake of glucose and free fatty acids and subsequently increases lipogenesis. Remember, lipogenesis is the synthesis of triglycerides. This effect of GLP-1 on adipose tissue is counteracted by its effect on increasing the activity of lipoprotein lipase, which promotes the breakdown of triglycerides. Overall, there is a decrease in adipose tissue mass. On the stomach, it decreases GI motility, leading to a decrease in stomach emptying, and therefore the patient feels full for longer. On the brain, GLP-1 acts to increase satiety and decrease appetite, leading to a decrease in food intake. And now we move to GIP. GIP is produced by the K cells of the duodenum and the jejunum in response to a meal. On the lower half of the diagram, GIP mechanism of action is interesting in that endogenously produced GIP at physiological doses promotes weight gain. However, exogenously administered GIP at pharmacological doses, especially when it is co-administered with a GLP-1 agonist, promotes weight loss. As can be seen on the diagram, GIP, like GLP-1, acts on multiple organs. The organs include the pancreas, where it increases beta cell proliferation and increases insulin and glucagon secretion. On the adipose tissue, GIP increases insulin sensitivity and therefore increases the uptake of glucose and free fatty acids, and subsequently increases the synthesis of triglycerides. This effect of GIP on adipose tissue is counteracted by its effect on increasing lipoprotein lipase activity, which promotes the breakdown of triglycerides. Additionally, chronic exposure to pharmacological doses of GIP in adipose tissue is thought to result in down sensitization of its receptors in fat cells, resulting in the catabolism of adipose cells. However, the major mechanism of action of GIP when co-administered at pharmacological doses with GLP One agonist is thought to be its action on the brain, leading to increased satiety and a decrease in food intake, which subsequently obviously leads to reduction in body weight. The effect of the two types of agonists administered together is thought to act in a synergistic manner in the central nervous system. Tirzepatide also results in an increase in metabolic rate by stimulation of the metabolic pathways that oxidize glucose, lipids, and branched chain amino acids. Remember, high circulating concentrations of branched chain amino acids are a hallmark of metabolic disorders, including obesity, insulin resistance, and type 2 diabetes mellitus. Now we come to the licensed indications for these drugs, and these indications are similar in the USA, UK, and Europe, and they are essentially to be used as an adjunct to a reduced calorie diet and increased physical activity in adults with a BMI equal to or greater than 30 kilograms per meter squared, or a BMI equal to or greater than 27 kilograms per meter squared in the presence of weight-related comorbidity such as hypertension or diabetes. Liraglutide and Semaglutide are also both licensed in children aged 12 and older for weight loss. Now we come to the method of administration. All three drugs are administered via subcutaneous injections, with Semaglutide and Tirzepatide being weekly subcutaneous injections and Liraglutide being daily subcutaneous injections. With all three drugs, you start at the lowest dose and you build up the dose gradually to the maximum dose that is tolerated. With Semaglutide and Tirzepatide, the increase in the dose is every 4 weeks, whilst with Liraglutide, the increase is weekly. This table shows a summary of the efficacy of the three drugs based on the findings of the randomized controlled trials on which the three drugs were licensed. The length the trials ran for ranged from 56 to 104 weeks. The figures for the mean weight loss are for participants on the maximum dose for each of the drugs. Tirzepatide had the highest mean weight loss from baseline in both non-diabetics as well as in diabetics, followed by Semaglutide and then Liraglutide. So Tirzepatide was the most efficacious, followed by Semaglutide, followed by Liraglutide. For all three drugs, mean weight loss was always greater in non-diabetics compared to diabetics. All the studies we've discussed so far involved the drug versus placebo. There has been only one completed head-to-head trial called the STEP 8 trial, which assessed Liraglutide versus Semaglutide. The results showed a mean weight loss from baseline of 15.8% with Semaglutide versus 6.4% with Liraglutide. Proportions of participants discontinuing treatment for any reason in this trial were 13.5% with Semaglutide versus 27.6% with Liraglutide. Separately, there is an ongoing randomized controlled clinical trial called SERMANT-5, which is comparing Mounjaro versus Wegovy, which is due for completion in November 2024. This table shows the frequency of side effects reported in the trials. As can be seen, the commonest side effect is nausea, which is probably not unexpected given that satiety and loss of appetite are two of the major mechanisms through which these drugs work. The frequency of nausea ranged from 1 in 2 for Semaglutide to just over 1 in 4 for Tirzepatide. The second commonest side effect was diarrhea. The other two relatively common side effects were vomiting and constipation. Overall, the commonest cause for discontinuation of treatment was GI side effects. The percentage of participants who discontinued treatment due to side effects was highest for Liraglutide at just under 10%, and the percentage for Semaglutide and Tirzepatide who discontinued from the study was just under 7%. And finally, the question of what happens to body weight after stopping treatment. There has been one trial of each drug. SERMANT-4 looked at Tirzepatide, step 1 looked at Semaglutide, and the trial published in Liver International in 2019 assessed Liraglutide. In all 3 trials, stopping treatment resulted in significant weight regain. So in order to maintain weight reduction, patients have to continue taking the drug long term. I hope you found this video interesting and useful. And please don't forget to subscribe, share, and turn on the notification button, and I'll see you in the next video. Thank you.